Hey guys, so when we talk about acute coronary syndromes, an acute coronary syndrome is one that you have chest pain for at least 20 minutes at rest, and the pain is substernal and dull and may radiate to the shoulder and neck. So I now want to just put a big 3 right here, because there are 3 total acute coronary syndromes. But I want to show you something, and that this at rest, if you were to just change this word to on exertion, it would change this acute coronary syndrome word into stable angina. In stable angina, you have a mere imbalance between myocardial oxygen supply and demand. So you are demanding, by doing your activity, more than you have a supply of. And if the pain, in terms of quality, is something that you can pinpoint exactly with your finger where it is, it's likely musculoskeletal. If it's stabbing or sharp and changes with respiration, it's pleuritic. If it changes with position, it's pericardial chest pain. And if it's tearing with radiation to the back, it is ruptured aortic aneurysm. Chest pain can also be gastroesophageal, but you always want to rule out the presence of an acute coronary syndrome before you go down this path. So I'm going to start by explaining the 3 acute coronary syndromes. And there is unstable angina, or UA, non-ST segment elevation myocardial infarction, or NSTEMI, and ST segment elevation myocardial infarction. So it all goes in the name that to diagnose a STEMI, you must have ST segment changes in at least 2 of the EKG leads. And these have to be, the EKG has to be negative, meaning no ST segment changes in 2 or more leads of the EKG to diagnose as an NSTEMI, and the UA is also negative. So these are absolutes. So the EKG, EKG, EKG. Now, when we talk about something called a cardiac marker or enzyme, the only acute coronary syndrome where you need positive cardiac markers is the NSTEMI. And this is absolute, okay? For the unstable angina, the cardiac markers have to be negative. For the STEMI, it can be positive or equivocal. So you could have a situation where you have ST segment elevation in 2 or more leads, but the cardiac markers are equivocal. So that is possible, but it's still a STEMI. Now, what is the difference in pathophysiology between these 3? So when you have, and just imagine that these are your coronary vessels, coronary arteries in each of the cases. So this is unstable angina, this is NSTEMI, and this is a STEMI. So in unstable angina, you have atherosclerosis. So it's somebody who has atherosclerotic plaques, and it's like in a stage that is, I guess, could be considered like enough so that there's plaque rupture, and the plaque rupture is enough to cause a compromise in oxygen delivery so that you have chest pain at rest. So it's just enough. In NSTEMI, there is an advanced formation of quite a large atherosclerotic plaque, and it is enough so that when it ruptures, there's partial occlusion of the artery. Okay, so it's enough to cause chest pain at rest, and it's enough to cause a change or an increase in cardiac biomarkers. In an ST segment elevation myocardial infarction, you've got the occlusion of the artery, and it's enough to cause not only changes, it is enough to cause electrophysiological changes so that in the EKG you have ST segment elevation in 2 or more leads that correspond to the area of the heart that's infarcted. And the area of the heart that's infarcted is determined by the vessel occluded. And I'll go over that again in another video. So let's clear this up. So since in all 3 acute coronary syndromes you have a compromise in oxygen delivery, of course in STMI it is an occlusion, which is an extreme deprivation in myocardial oxygen delivery, you're going to give medications in all 3 cases that deal with that. And so the morphine is for the pain, so you give morphine. You give oxygen, of course, because they're deficient in oxygen. You give nitrates. And that works on the vascular endothelium. And you give aspirin. And that aspirin prevents further infarction. So now, these 4 you give in all 3 acute coronary syndromes. Now I'm going to go on to what you do differently in each one. So remember I showed you that there's a basic difference in the pathogenesis between UA and STEMI versus STEMI. And in STEMI, the entire vessel is occluded. So I like to think of it as clogged or closed. And what you do in clogged or closed is you cath. So that's another C. Catheterization is the first line. And another treatment modality is thrombolysis. Now thrombolysis is second line. So if you do not have a cath lab immediately available and you're within 12 hours of onset of the myocardial infarction, you can give thrombolytics. But if the patient has contraindications to thrombolytics, and I will go over that in a separate video, but a main one and a common sense one is history of severe hemorrhage, history of brain hemorrhage. You're going to have to make sure the patient gets to a cath lab because you cannot give thrombolytics. So if there are contraindications, you got to make sure they get to a cath lab and you do not give them thrombolytics. In UA and non-ST segment elevation myocardial infarction, you give heparin first. And this is because, see, remember I discussed that unstable angina and non-ST segment elevation myocardial infarction are both due to plaque rupture. So the heparin acts on thrombin. And it stops this, it kind of slows down this process. And in addition to heparin, you're going to apply something called a TIMI risk score. to the patient. And what the TME risk score does is what the TME risk score is, it's a calculation that kind of categorizes a patient as low risk or high risk. And how the calculation is made is a bunch of factors: the patient's age, aspirin use, history of anginal episodes, history of coronary artery disease, and so on and so forth. So it's an estimate of mortality risk. So if the patient is high risk, you have to go to the cath. But before you go to the catheterization, you have to administer a glycoprotein 2B3A inhibitor or bivalirudin. If the patient's low risk, then you subject them to, or you administer a submaximal stress test. And if that submaximal stress test is positive, you're gonna go this way and give the GP2B3A inhibitor or bivalirudin and catheterize. If it's negative, then you proceed with medical management. And I just want to remind you that, and actually this is supposed to be 3A. I just want to remind you that in all coronary syndromes, after the patient's stable, you're going to want to administer beta blockers, statins, and ACE inhibitors. And you've reached the end of my video.